I'm going to talk about abnormal liver tests. And let's start. Okay, so a couple of things to remember. Abnormal liver tests can occur in asymptomatic individuals. So people who've got abnormal liver tests don't necessarily have symptoms and signs of liver disease. And abnormal liver enzymes, there's a couple of parts to the abnormal liver test. Firstly, we've got the abnormal liver enzymes, and they reflect liver damage or impairment of bile flow. They do not reflect liver function. So to call them liver function tests is actually incorrect. INR and albumin reflect liver synthetic function, so they are function tests. And similarly, bilirubin is a function test. And I'll talk a little bit more in some detail about this shortly. But bilirubin reflects the function of the liver to detoxify metabolites to transport organic anions. So they're the function tests. The enzymes are really liver-associated enzymes, or the liver tests, if you want to just call them that. So they're not liver function tests. So let's talk a little bit about the liver enzymes. They reflect liver cell injury or impairment of bile flow, and depending which enzymes are involved, either or both of these may be going on. So the enzymes we measure are the transaminases, which are aspartate aminotransferase and alanine aminotransferase, both AST and ALT. For those who probably don't remember, the old names are SGOT and SGPT, but we now call them AST and ALT. We measure alkaline phosphatase, and they're the common ones that are usually done. Less commonly, we measure, and there's a typo there, I apologize for that, gamma glutamyl transpeptidase, GGT, lactate dehydrogenase, and 5' nucleotidase. The latter two are measured fairly infrequently, certainly when trying to assess liver function. So let's talk a little bit about each of those and what they mean. The transaminases. Once again, as you can see, I did this myself, and it's full of typos, but I tried to find as many as I could. The transaminases, the normal range, and we don't usually look at this, but we should. We should separate, especially ALT, difference between males and females. And even though some labs will put the high range much higher, normal upper limit of normal much higher than what's usually recommended. Any labs, in males, 29 to 33 is the range for normal, and for females, 19 to 25, just a little bit lower. The elevated transaminases reflect hepatocyte, liver cell injury. But you've got to remember, some of these enzymes are present elsewhere. AST, for instance, is present in skeletal muscle, it's present in heart, it's present in kidney, present in brain, as well as the liver. So elevated enzymes, AST, can occur with damage to any of these other organs. So an elevated transaminase is not necessarily specific for liver injury. It's more common in the liver than in other tissues, but it's still not specific. ALT does occur in other tissues, but it's much more liver specific. So for instance, if you have severe muscle damage, say with rhabdomyolysis, you may have very high AST levels. ALT can be elevated, but certainly nowhere near as high. And ALT has been shown, and I think AST also for that matter, has been shown to increase with abdominal adiposity. And part of the reason that some of the commercial labs will put the normal, upper limit of normal for ALT and AST higher than the numbers that I've suggested on this slide is because with the increasing size of the American population, as you know, obesity is a significant epidemic right now. The normal range, and I put normal in quotation marks, for AST and ALT is much higher. Because if you define normal, and what the commercial and other labs do is as mean level plus or minus 2 standard deviations of the population as normal, then as people get bigger, the ALT and the AST go up, and so the normal range goes up. So really that often many of the labs will give you an upper range of limit or upper limit of normal for these transaminases, which is really higher than it should be. It's always worth keeping in mind. There's one other point I should also mention at this point as well. I didn't put this on the slide, it's just a little sort of side. If you look at people with on dialysis, they will have extremely low levels And anyone who's got extremely low levels of ALT and AST, always look at their renal function. Next enzyme to talk about, alkaline phosphatase. This is increased in impairment of bile flow. It's also increased in mass lesions of the liver. If you've got metastatic disease or something else in the liver, part of that is because the mass will usually compress bile ducts in the vicinity. Alkaline phosphatase is actually synthesized in biliary cells. So if there's problems with the biliary flow or there's mass lesions compressing associated bile ducts, often the alkaline phosphatase will go up. Once again, it's not specific for the liver. It can occur in the liver, the bone, placenta, and intestine. And you can actually order through the lab to fractionate it. If you have someone who you don't really know whether the source of this alkaline phosphatase is, you can actually ask the lab to fractionate it. You can see where it's coming from, whether it comes from bone or liver. They're the two main ones. Intestine is a small source. And placenta is an important source because measuring alkaline phosphatase in a pregnant female can give you very, very misleading results. So if you have a woman who's got pregnancy-associated cholestasis, there's not much point in measuring alkaline phosphatase. You know it'll be high. That's why you measure bile salts in those particular people instead. It's higher in children, and that's because of their bone origin. The bones are growing. There's a lot of osteoblastic activity and osteoplastic activity going on. So, especially osteoblastic in the growing children, and so you'll have a higher alkaline phosphatase level. So the normals for children are much higher than the normal for adults. And then sort of the other end of the spectrum, in older people, especially females, it tends to be a little higher as well. Whether that's from liver or from bone is not really quite clear. So the values vary depending upon the age of the person and also depending upon the physiologic states such as pregnancy and so on. Next one, GGT. We measure this less frequently, and the reason of that is because it's a little bit non-specific. GGT occurs both in hepatocytes and biliary cells, as well as a variety of other tissues. So as a measure of liver injury, it can be fairly non-specific, which can occur in lots of other tissues as well. In neonates, it tends to be very high. And because of the widespread presence in many organs, it's got limited utility. One of the uses that we occasionally will put to it, if we have an alkaline phosphatase and we don't get, or the fractionation of the alkaline phosphatase is a little equivocal, we can actually look at GGTP. And if the GGTP is high associated with the alkaline phosphatase, we can sort of infer that possibly, most likely, the alkaline phosphatase is liver in origin. Not used very much. The other thing about, because it occurs in hepatocytes, it's very prone to, and I should actually put this in the slide, but I didn't, it's very prone to induction because it's an enzyme which is in the microsomal part of the subcellular fractions, and things like alcohol and in particular anti-seizure medicine, Dilantin and so on, they can actually increase the microsomal oxidase, the microsomal fraction of the cells by inducing enzyme production, and they induce GGT. So someone who is on, say, Dilantin, they'll quite often have an elevated GGTP in the absence of any significant liver disease. So it's got a lower specificity. You don't use it all that much for that reason. LDH, once again, occurs on a whole lot of different tissues. It's less sensitive than aminotransferase to identify liver cell injury. Once again, you can fractionate it. There's 5 or 6 different subtypes. The major use actually is, I find, is in the diagnosis of hemolysis. It's said that ischemic hepatitis will have very high LDH. In fact, you can differentiate that from viral hepatitis. I don't find that as useful. The major use I put to it is if I question the presence of hemolysis. It's a reasonably good marker of hemolysis, along with all the other markers we use with hemolysis. And 5' nucleotidase, just for completeness, used to be used a lot more than it is now. Once again, it occurs in many organs. The advantage of this, it's only secreted into the blood, even though it's present in many tissues, it's only secreted into the blood by hepatobiliary tissue. So in other words, if you do have a 5' nucleotidase, it's coming from the liver or the bile ducts. And once again, you can use that as a marker of cholestasis, as with GGT, to demonstrate that alkaline phosphatase is in fact of biliary origin. Not used very much at all. Okay, so that's the liver enzyme. Let's talk about the real liver function test. And there are three that we use commonly: albumin, INR, and bilirubin. Albumin is synthesized in the liver. As you get older, the levels fall. So, you know, a normal young adult should have an albumin level of close to 4 or higher. In an older person, especially someone with low muscle mass, such as an older lady, their albumin normal could be 3.6, 3.7, something like that. A low level can reflect reduced liver synthetic function. So in other words, it can tell you that the liver is not working as well as it should. But remember, low levels can occur in lots of other things. They can occur because you're losing albumin from the kidney, nephrotic syndrome, losing it from the GI tract, protein losing enteropathy, and many GI pathologies can be associated with protein loss in the GI tract. And the other thing, of course, is that a low albumin can certainly reflect poor nutrition. And someone that's not eating well can have extremely low albumin levels. Prothrombin time, INR, it's not usually included when we measure, you know, we ask for liver function tests or liver enzyme, but I think it's a very important measure of liver function, because once again, it's a measure of a number of the clotting factors which are synthesized in the liver. When these, the liver's not, synthetic function is depressed, the INR will become prolonged. It doesn't make these clotting factors as well as it should. You can actually also get clotting factors in people with jaundice who have a cholestasis, and where you don't absorb the vitamin K, which is necessary to make these clotting factors. And so the difference between INR elevation due to liver synthetic dysfunction and due to the inability of vitamin K to be absorbed because of cholestasis or because of whatever, can easily be demonstrated by giving the person vitamin K. Someone who's got severe liver synthetic dysfunction, you give them vitamin K, it's not going to help the INR. If they've got a problem with absorption, malabsorption of vitamin K, either because of cholestasis, you've got pancreatic steatorrhea or whatever, you give them vitamin K, it's going to help. And of course, if you're malnourished and they're not eating enough vitamin K, then they're going to have a prolonged INR, which can be reversed by vitamin K. One very important point about INR, it does not predict the risk of bleeding in liver disease. Coagulation and coagulation abnormalities in liver disease are a very complex subject. The reason being that the liver makes clotting factors, as is measured in the INR. It makes anti-clotting factors, plasminogen and some of the other factors. It makes a whole range of clotting factors and sort of anti-clotting factors. And so for that reason, there's a balance. And just to look at the INR and say this person's got a great risk of bleeding in liver disease is inaccurate. So you really can't just look at INR and say they're bleeding. And so if someone's going to have a procedure and they've got a slightly prolonged INR, they've got liver disease, and you think the INR is due to the liver disease, it doesn't necessarily predict the fact that they're going to bleed, and correcting them with fresh frozen plasma may or may not protect them against any risk of bleeding. And finally, I want to talk about bilirubin. As you all know, it's a yellow pigment. It's derived from the breakdown of hemoglobin, which is taken up by the liver. It's conjugated glucuronic acid. The conjugated bilirubin is then secreted into the bile. The excess conjugated bilirubin is cleared by the kidney, producing bilirubinuria. The unconjugated bilirubin is water insoluble and is not excreted in the urine. I've got a little diagram here. I don't know if it projects very well, but over here is the reticular endothelial cells, particularly in the spleen. The red cells are broken down. Bilirubin is formed from the breakdown product of the heme. It's then combined with albumin, circulates around, is taken up by the liver. This is unconjugated bilirubin. In the normal circumstance, virtually all of that is taken up by the liver. It's conjugated with glucuronic acid, producing mono and diglucuronide, water soluble, gets secreted in the bile, goes down into the intestine, where the intestines break it down into urobilinogen, stercobilinogen, which then colors the stool. A little bit sort of gets back out of the intestine and gets it's water soluble, so it can get to the kidneys and get excreted. So we can, under normal circumstances, have a little bit of urobilinogen in the urine. Usually there's no bilirubinuria. Now, if there is a defect in the uptake or some sort of congenital abnormality in conjugation, such as Crigler-Najjar syndrome, or the common uptake defect that we see in a large number of people who are otherwise normal, is Gilbert's syndrome, where there's a defect in the uptake of bilirubin. So you have a buildup of unconjugated bilirubin. Usually the levels don't get very high. If you have hemolysis, there's a big buildup, there's an increased load of bilirubin. So you may have an increase in bilirubin. In a normal situation, the bilirubin uptake mechanism in the liver is so efficient that in people with hemolysis, the bilirubin level never gets very high. And one of the big differences between unconjugated and conjugated bilirubin is that the unconjugated bilirubin is water insoluble and will not be excreted in the kidney. So someone with Gilbert syndrome, someone with hemolysis, in the absence of any other significant liver disease, will not have bilirubinuria. So if there's bilirubin in the urine, you can say this person's got something going on in the liver because the conjugated bilirubin is elevated. I like to think of unconjugated bilirubin as not really a liver function test. The conjugated bilirubin is the liver function test. Okay, so what causes hyperbilirubinemia? Well, I sort of mentioned some of it. You can have unconjugated hyperbilirubinemia, where there is absence of bilirubinuria, increased production due to hemolysis, congenital abnormalities of bilirubin uptake or conjugation, and I've mentioned a couple of them. Crigler-Najjar syndrome is a rare syndrome where there is absence of the conjugating enzyme, the glucuronidation enzyme. And then you can have conjugated hyperbilirubinemia, which to my mind is a liver function test. And it can occur either because there's hepatocellular injury in that the liver liver is not able to either conjugate the bilirubin, or more likely, it does conjugate it, but it be able to transfer, which is the rate limiting step in the bilirubin pathway, transport the bilirubin from the conjugation to the bile and excrete it in the bile. So you have a buildup, gets back into the blood, excreted in the kidney, so you get dark urine with hyperbilirubin, with bilirubin. And then the other situation in which you have increased bilirubin is because there's impairment of bile flow, either because large duct obstruction or because of intrahepatic cholestasis due to a variety of causes. So the bilirubin level itself doesn't tell you whether it's cholestatic or whether it's, in other words, due to impairment of bile flow, or whether it's due to hepatocellular injury. How do I get rid of? I can't see the bottom of my slide there. Can you see it? Okay. So hepatocellular injury is usually associated with transaminase elevation, and cholestatic injury is usually associated with predominant alkaline phosphatase elevation, and sometimes you can have a mixed pattern, especially in certain types of drug-induced liver injury. So the bilirubin elevation itself can occur in all situations. If you have a very high bilirubin level, that usually implies intrahepatic causes rather than extrahepatic causes. So if you have a benign bile duct obstruction, say due to gallstones, then the bilirubin level usually never gets much beyond 12, 14 max. If you have intrahepatic diseases where there's hepatocellular involved problem, then the bilirubin level gets much higher. Sometimes you can get very high bilirubin levels if you have a combination of things. For instance, if you have hepatocellular injury and hemolysis, bilirubin levels can get extremely high. If you have hepatocellular injury and renal dysfunction, the bilirubin can't be got rid of by the kidney, the bilirubin levels can get extremely high. People have come up with this thing, which I don't find all that useful, but I thought I'd just put it up just to show it to you. Someone has come up with something called the R factor. Basically, if you look at the ratio of the ALT to the alkaline phosphatase and you compare them to the upper limits of normal for both of these values, and if the ratio is greater than 5, it leans you towards hepatocellular injury, less than 2, cholestatic, and somewhere between 2 and 5, it's a mixed pattern. We'll have transaminase elevations. You can get some clues on what's going on by looking at the pattern of transaminase elevation. If you have very high levels, say, to find out here is greater than 25 times the upper limit of normal, that almost always indicates an acute hepatocellular injury rather than a chronic injury. There are a couple of exceptions. People with chronic hepatitis B that flares, people with autoimmune hepatitis can sometimes do it. But usually, if you have very high levels, it usually means an acute injury. They usually don't have underlying chronic liver disease, with the exceptions that I mentioned. Extremely high levels, 50 times normal or even higher. A couple of indication things that happen here where that's likely to happen. One, ischemic hepatitis can occur, and it gets better usually fairly quickly once the ischemia or the hypotension is resolved. And the other thing, always, if you have a level like that, always think of a combination of Tylenol toxicity and alcohol. That combination can produce extremely high levels. Other things to look at is look at the ratio. An AST to ALT ratio, if the AST is usually less than 400, it's not very high, usually, and there's some studies indicate about 90% of cases will indicate alcohol as the cause. In most chronic liver diseases, chronic hepatitis C, NASH, ALT is usually higher than AST unless significant fibrosis occurs. So if you have someone with NASH, you see the AST is higher than the ALT, not necessarily a 2-to-1 ratio, but runs routinely higher than ALT. You are very suspicious that this person may have significant fibrosis and not simple steatosis. So as I said, the difference between acute and chronic liver injury, acute usually has much higher transaminases. Usually they don't have underlying chronic liver disease. So the albumin is normal because the albumin's got a half-life of several days, so it's going to take a while before the albumin level falls. INR actually will rise in someone with acute liver injury because the half-life of the clotting factors is much less. And of course, they'll have no clinical stigmata of chronic liver disease, ascites, muscle wasting, and the like. Chronic liver disease will have a low albumin, they'll have the clinical stigmatas. And the other thing to always look at is a low platelet count as a manifestation of portal hypertension. If you had to do one non-invasive test to diagnose cirrhosis, I would choose platelet count, because that has actually got the best predictive value of the presence or absence of cirrhosis. Remember, of course, that you can have low albumin, you can have low platelet count for non-liver disease related things as well. But in the context of chronic liver disease, these are important clinical findings to look at. So someone comes in, they've got abnormal liver tests. Based on sort of some of the criteria and some of the things I've mentioned, what do you think about it? First thing I ask is this hepatocellular, is it cholestatic, or is it mixed? And if it's cholestatic, you have to think about, is it large duct obstruction? Do you want to do an ultrasound to make sure there's no ductal obstruction that can be dealt with mechanically? Is this an acute thing or is it chronic? And then the next thing you want to look at is what could be causing this? And I'm not going to go through a list of all the etiologies of abnormal liver tests, but I sort of think of it in terms of viral, immunologic, toxic, metabolic, and included in the metabolic thing, not only NASH, but some of the congenital or inherited conditions such as hemochromatosis, Wilson disease, and so on. And depending upon the clinical context, alpha-1 antitrypsin deficiency is another one that you should always keep in mind. And then the other thing you need to do, we need to assess how bad off are they? How bad is the liver damage? So what we look at clinically, are they jaundiced? Do they have ascites? Do they have encephalopathy? Do they have muscle wasting? And we look at lab values. How high is the bilirubin? How high is the INR? How low is the albumin? Level of transaminases, even when it comes to many thousands in acute liver injury, does not correlate with disease severity. So just because someone has an AST, ALT of 3,000, 4,000, doesn't necessarily mean that they've got very severe liver injury. The elevated bilirubin and the INR does give you a measure of how severe the disease is as a clinical feature. But the level of transaminase itself is not an important predictor of degree of disease severity. We use imaging. We use imaging to look for, are they cirrhotic? Do they have cirrhotic morphology? Do they have portal systemic changes? Portal systemic collapse or ascites, splenomegaly, and so on. And then we use a number of things to measure the degree of liver injury or the degree of severity, the degree of fibrosis. We use liver stiffness measurement, and then there's a couple of other non-invasive fibrosis scores, which I'm going to mention, which I find very useful and can be done very quickly. And as usual, there's an app for that. And I will actually, I'm going to redo some of these slides because I think I need to, which I will send to you guys because I want to improve it. But I'll also include the app, which I think is worth getting. I'll mention that at the end. Firstly, we have, oh, did I put this in here now? Okay. The CHILD-PUGH score we use. That's old. That first was introduced in 1975 as a measure of mortality associated with liver disease. Initially introduced by a bunch of surgeons who wanted to see the outcome following surgery, how well liver disease patients would tolerate surgery. And there are 4 values we look at, 5, I'm sorry. Bilirubin, albumin, PT, INR, ascites, hepatic encephalopathy. The problem with this is that 2 of them, the ascites and encephalopathy, are subjective. And so you can actually, in the days when we used to use CHILD-PUGH score to stratify people for liver transplantation, you could actually cheat a little bit by saying, well, the person doesn't have ascites now, but he's on diuretic, so he really does have ascites, we'll give him an extra point. Yeah, they're a little bit slow today. Yeah, we'll give them an extra point. They're touch encephalopathic. So you could cheat a little bit, not with hepatologists or dishonest people, but that possibility was there. So based on the CHILD-PUGH classification, and each of the values gets 1, 2, or 3 points, as you can see in this table, you can classify it into Class A, Class B, and Class C. And I don't know whether you can see the bottom of the slide or not, because I can't. But 5 to 6 is A, 7 to 10 is B, and beyond that is C. And this is associated with clinical outcome of disease. More recently, we use the MELD score, and I put the formula up there. No one remembers that because it's all in, there's an app for that, and you have a value, a MELD score, and the higher the MELD score, the worse the prognosis, the worse the mortality rate. Nowadays, we don't only use the MELD score, but we've found that serum sodium can actually play a role. So nowadays, we use the MELD sodium score. And we use this both for stratifying people on the liver transplant wait list, but also to evaluate their prognosis, and also if they're going to have some sort of surgery, non-related liver surgery, how well they tolerate it. Those with a higher MELD score will tolerate it less well. We use it to evaluate whether or not the person is suitable for TIPS. If a TIPS score is greater than 18, as a rule, they will not tolerate the TIPS very well, and you should probably avoid putting in a TIPS. So they can't tolerate the shunting of the blood around the liver. These I find very useful. They're very easy to use. And once again, there's an app for these. You can find them on Google, and I'll give you the app where it's got everything all in one place. And these are non-invasive fibrosis tests. If you have a person with NASH, with chronic hepatitis C, and you ask the question, have they progressed beyond simple inflammation or just simple steatosis, who have some degree of fibrosis? There is the APRI score, which is simply the AST compared to the upper limit of normal for the AST divided by the platelet count, multiplied by 100 and get a number. There is the FIB4, which uses age, AST, platelet count, and ALT. a little bit more mathematical because it involves the square root of the ALT. And then the other one is the NAFLD fibrosis score, which is even more complex because it involves age, BMI, presence or absence of diabetes, AST, ALT, platelet count, albumin. And you get a number out of this, and that gives you a reasonable guide as to whether or not there is fibrosis present. And once again, there is an app for all of this, and I'll talk about that right at the end. We also measure, do some imaging studies. We measure liver stiffness, and there's a number of ways of doing that. MR elastography is not available at Georgetown. Shear wave ultrasound is, but we use FibroScan very, very frequently. So if you have someone with some sort of chronic liver disease and you wonder, have they progressed to significant fibrosis, you can set up a FibroScan. It's a very simple test. It uses ultrasound technology. The sound wave gets into the liver, and instead of getting a picture, you get a number, which is a measure of the speed of the sound wave. The stiffer the liver, the faster the sound wave progresses, and stiffness is correlated very well to hepatic fibrosis. And I don't know whether this projects well or not, but basically depending upon the type of disease and the FibroScan number that you get out, you can estimate whether they have F0 to F1, which is minimal fibrosis, F2, which is mild fibrosis, F3, which is severe fibrosis, or F4, which is cirrhosis. So, for instance, if you have, say, fatty liver disease, you have a liver stiffness score less than 7 kilopascals, this is likely to be low fibrosis or minimal or no fibrosis. Between 7 and 10, it's F2, mild fibrosis. Between 10 to 14, it's severe fibrosis. And if the score is greater than 14, this person likely has cirrhosis. And the numbers are a little bit different for other diseases, but the principle is the same. And these tests can be ordered very easily. We do it up in the Transplant Institute all the time. The other advantage of, once again, I put these slides up and I'm going to have to sort of change these around because I don't think they project very well, is the attenuation parameter. What they look at is the way that the sound wave gets attenuated, and this correlates with the presence of fat. And the greater the attenuation, the more fat. And depending upon the attenuation, you can estimate how much fat there is in the liver as well. I'm going to try and redo some of these slides, which I'll send to you. My final slide is to assess liver function, to assess liver disease, the liver biopsy. It gives you two advantages. Nowadays, with our all of the blood tests we do, we can quite often come up with a cause, with a diagnosis. And then with those non-invasive tests that I've mentioned, the APRI, the FIB4, and so on, the FibroScan, and so on, we can actually come up with a measure of disease severity. If there's ever a doubt, A as to the cause, and B as to the measure of disease severity, some of these labs, some of these tests have produced discordant results, then we resort to liver biopsy. So it actually, we use it much, much less frequently than we used to, because it allows both assessment of cause and measure of disease severity, which the other tests, which we don't, which may or may not be able to be ascertained using the other tests I've outlined. So that's a very quick run through assessment of abnormal liver tests and how we assess people with liver disease. And you can still hear the app, which is used to evaluate this, is something called HepCalc.